This conference will now be recorded.
We have someone else who just joined on the telephone. Care to identify?
Sure, John Appler here, Jake. How are you guys doing?
Good, John. How are you?
Hey, John.
Yeah, hey guys, how you doing?
Good. How are you doing?
Can't complain.
Has it
Tests are
got
coming in okay.
Has it got any warmer in Maui?
Well, it stopped snowing a little bit warmer actually, so we can't complain so much.
Yeah.
The good news is only the 60s. The bad news is no one owns pants over here.
You might want to clarify that nobody owns long pants.
Yeah, that's a good point.
Oh, that's quite funny.
Not quite
That's
that crazy. You're right.
Good point,
Yeah.
Dennis.
You're looking at a lot of white kneecaps, I guess.
Yeah, exactly.
No.
Exactly.
Well, it's been cold here today, more chilly here today, but no snow, but it has been chilly. It did rain. Of course, we all like it when it rains. Everybody's very happy when it rains around here.
Yeah.
So, yeah.
Sylvester,
Hello, Sylvester.
Hello,
good
everybody.
evening.
Hope you
I
can
missed
hear
your
me.
comment about names. What were you saying about names?
Oh, I was saying I'm gonna try to I'm personally gonna make an effort not to identify full names if I can.
Oh,
Only because some people have mentioned that they're not happy about that, and we're not going to stop recording these calls, that's for sure. And as I pointed out in my email this week, if people are sensitive, they should let me know, and then I'll be even more. But this won't last long. I'll remember this time, and then I won't remember next time. So, excuse me. All right, let's see. Do I have everybody? Ken? Oh, Ken. No, I don't have Ken. And Sierra, Les, Rita. Rich Stevens, I have. Rich Jackson, I have. All right, I think I have everybody, so we can start to roll here. And so I'm just going to call the names that I see, and then if I miss anybody, of course you'll let me know. So I have Jake H, Dennis C, Rich J, Joe B, Len S, Paul F, Rich S, Les S, John A, Sylvester M, and Ken A. So
feel free to use my last name. I don't care.
oh, okay.
That's
But
just
then
that's gonna get complicated.
It's a slippery slope, Jake.
It is. Yeah.
It's a slippery slope, and I'm not going to be good at this right the way through, but I'm making the effort just so that you guys know.
Okay.
And really, Bill Franklin. Oh, he left. Bill Franklin should be on to hear me do this because he and I discussed this. All right. Did I miss anybody?
Peter
I'm
K.
not sure I heard my name, Rick. Dennis.
Oh yes, I got you at the top, and then Peter must have joined us whilst I was reading out. Hi, Peter. Hey,
Greetings.
Peter, do you have any long pants?
Yes, I'm wearing jeans today.
Oh, okay. Because you missed the discussion. We already talked with Mr. Appler about long pants.
Oh, he's
told
on
him no
the sunny side.
Now, why is Sylvester wearing a jacket down there in Atlanta? What's going on there?
I'm in California.
Oh,
California, you're not in Atlanta.
what made me think you were in Atlanta? You've always been in California?
That's where he's from.
I'm from Atlanta.
Oh, okay.
Been in
But-
California 50 years.
It's
The
all right.
question is even more
You
pertinent,
never lost.
Sylvester. Why are you wearing a coat if you live in California?
Well, it's a little cool here today, and
That's
I just came from outside. I'm always running late.
Okay. All right. So we have one new gentleman with us who I have talked to 2 or 3 times. Len has had some communication with, and his name is Rich S. There you go. And we met in an indirect fashion in that when I was changing into my blue togs a couple of weeks ago, week and a half ago, Rich's cousin, another Richard, was changing next to me, and we started talking, and he had had a radical prostatectomy last year, but with a very low PSA, and was doing fine. But we talked a little bit about germline risk, inherited risk, and then afterwards I talked more with Richard, and he said he had a cousin who had had some recurrence recently, and I said, well, that, you know, definitely put him in touch with me, and that's how I got started talking with Rich, and invited him onto the call, and I will let him fill you in on the degree of his recurrence, and maybe some of the wiser heads who are on this call can give him their thoughts on how he should pursue a situation. So, Rich, if you're comfortable, maybe you can introduce yourself, your age, you know, where you're being treated, your background, your disease background, that is, disease demographics, and then pose your questions to the guys that are on the call, please.
Okay. First, thanks for having me. Appreciate it. I am 58 years old and had my cancer diagnosis 3 years ago. I had the prostatectomy in April of 2016, a Gleason 9, and it was performed at Mount Sinai by Dr. Tawari, and this was 3 years ago. Most recently, my PSA levels have started to climb again and accelerate at the same time. And most recently have crossed that 0.2 threshold, which puts me into a recurrence. So 3 years removed from the actual surgery, the Gleason 9, I'm officially at that recurrence state. And with that, I've met with my oncologist and had some, preliminary discussions about where are we going with this. And the initial discussion is hormone therapy, and I kind of get it in research and conversation, and the fact that it does inhibit further growth, and it makes sense to me, on the surface. So I'm kind of resigned to the fact that that's something that I will have to undergo, fairly, shortly. Where I'm kind of at a crossroads is, being that my recent PSA is at a 0.27, there's kind of conflicting information as to whether twofold here. It's high enough to provide a readable scan, And number two, the scan itself, whether it's a conventional MRI and CAT scan versus the Axeman scan, which I have access to, but it would be out of my own out-of-pocket expense. So what I'm conflicted with is if I do proceed and say, look, I want to do this scan. I want to do the Aximum. It's state of the art. It's going to read things the other ones can't. It's going to see things and perhaps, map me better or more precise as far as future, radiation treatments go. Then there's the viable argument that, hey, you're too soon for this. You should wait it out. Get yourself up to a 0.6 or thereabouts so that we can get a definitive read as to what you've got and react accordingly. And I hope I've provided enough backup to kind of further the discussion. That's where I'm at.
Yeah. And I'll add a couple of things, gents, for you. One is that Rich is now being seen by Dr. Bobby Liao, who is part of Mount Sinai, and who I got to meet at the event because he was also the doctor of the other guy, the Alan Messer, who walked with me, and I was very impressed with him. Secondly, that the Mount Sinai ran a somatic test on the tumor sample from the radical prostatectomy, and Rich has a couple of pretty unusual mutations that I had not come across before. I'm not even sure that that Professor Bill was that familiar with them in prostate cancer. He was very familiar with both of them, but not in prostate cancer. One is called IDH1, and that is treatable with olaparib. I don't know quite what type of mutation it is, whether it's a repair mutation or what. I mean, Bill is going to get back to me and tell me a little more, or he'll tell us at some point. And the other one is called CCND1, and that's also treatable with another couple of drugs. What's the name of the drug that's, do you recall, Rich, for that one? I always forget. We can never pronounce it. Palcalib.
No, sorry, Rick. No.
Hold on. I'll tell you guys in a second. Palbociclib. And I've heard of that drug before in the context of other cancers, but I don't know much about it, how it works, what it is. But both of those drugs were pulled out, and both these mutations are being investigated for prostate cancer in clinical trial. So it's not like it's a proven, known prostate cancer mutation, and both of them are only seen in about 1 to 3% of men with prostate cancer. And of course, we don't know whether these are germline or somatic because they showed up in the somatic test. The only way we'll know that is if they were to show up again in a germline test, in an inherited cancer test. So those were just a couple of things that I wanted to add. So, let me throw this one out. I mean, what do you do when your PSA starts to go back up? You really would like to know where that cancer is, but it isn't really at 0.2, 0.3. You're really rolling the dice a little bit if you go with one of the more advanced scans. Do you let it go and wait until you get up to a 0.6? Do you take an LHRH drug right now, which will suppress it, and then wait until, God forbid, you become hormone resistant? Has anybody faced this issue, and what are your thoughts on it?
I have some overlap and some differences, right? I'm 58 now and was diagnosed around the same time. Had a whole bunch of Gleason 9s, had surgery, but this is where we start to differ. My surgery was November of 16, so it's close. But, you know, my first PSAs were only 0.9 and then a doubling time of 3 weeks. So it's not like I had to wait around to decide to do imaging. Excuse me. So I went ahead and did the carbon 11 acetate because I wasn't familiar with PSMA, and I don't think Aximan had come out yet. But I didn't know if the group, I mean, the idea of waiting around to get a higher score to get good images would be pretty hard for me to do.
Same here.
And I didn't know how people felt, you know, just on the technical side. My understanding was when my PSA gets high enough, I'm going to go get a PSMA. But I didn't know if people think the Aximan is equivalent or not.
Rich, this is Peter. I have a couple of questions for you before I make a comment. With your post-prostatectomy, was there any extracapular extension? Was there any invasion of the seminal vesicles or any lymph nodes involvement or anything like that?
No, none of the above. You know, Dr. Tawari actually, you know, from what he said to me, he for lack of the proper terminology, he went back in after he removed the prostate, scraped some more, and you know, cleaned it up, and all of the post-surgical testing, you know, showed that nothing had gotten beyond. Even prior to the surgery, my bone scanned, it was contained within the prostate. We're looking at a 9 Gleason, but it's wholly contained within the prostate and did not break, you know, that wall. So yes.
Okay. Well, the usual way until recently was that when you started getting reoccurrence, you went for radiation when you got to about a 2.0 to the prostate bed. Now, with the advent of high-tech scans like the PSMA or Oxman and so forth, you have the opportunity to look and see if there's actually any involvement, any mets outside the prostate bed. Which when I went through this, I didn't have that opportunity. However, recently, last year, I did do a PSMA scan because I had second reoccurrence beyond my IMRT radiation, and I found it had gone metastatic to some lymph nodes in my abdomen. To get into a PSMA trial to avoid the cost, and there are a few places. Len can speak to the one on the East Coast, and I have a friend who just got in the trial, just came back last week from the one in San Francisco at UCSF that does the gallium-68 PSMA. You want to have a PSA, you want to let the PSA climb to I did mine at 0.8. Usually you can get into the trial like 7, 0.8, 0.9, something like that. And the gallium-68 is very effective there. The Oxman scan is not quite as effective until you get a higher PSA. The odds of really picking up exactly where the spread is aren't as good. However, starting on hormone treatment will preclude you from getting into a trial. You can't be on hormone treatment to get into a trial like this. So, I don't know how fast your PSA is climbing. You know what the doubling time is. Like Joe mentioned, 3 weeks. I don't know what mine was. Mine was about 7 weeks or so when it was doubling. So that's my comments. I mean, you've got a number of things to think about. I wouldn't panic, you know, with a 0.2 PSA. You know, things are not going to get out of control or anything, even if you let it climb closer to 1.0.
Was it undetectable throughout the interim until now?
Yeah, the first, 2.5 years, but you know what, undetectable being 0.3, 0.4, 0.7, and then the jump to 1.4, and now the jump to 0.27. So it's accelerated, and it's obvious that,
What's
it's going to continue to climb. I'm sorry?
How fast is it accelerating?
Well, I just got the confirmation of 2.7, I guess, a few weeks ago, but it had been 1.14, only a month or two before that. So it's starting to really accelerate.
It's doubling within about 2 month range right now.
Correct.
So that's indication something's on the move.
Right.
I would investigate. The high-tech scans are expensive, but if you can get into a trial, for $500, you can fly out to San Francisco and do this in one day. So,
all right.
Most you might pay $900 for the gallium injection, but anyway, there's options, but you've got to talk. I would talk to your doc and really explore it and see what the right thing to do is.
Yeah, that's where I'm going with it. Go ahead, Rick. That's where I'm going with this.
Yeah, I was going to ask who else has some thoughts. Len, what are your thoughts on this?
Yeah. Rich, you and I have been emailing back and forth a bit. And as you know, if you took a look at the chart I sent you, using Axumin, only 37% of lesions will be picked up when the PSA is between, I think it was 0.2 and 1.0. So right. You may be out of pocket several $1,000s and come away with a report that says there's nothing definitive. I can tell you that I just had an Axumin scan in December 2018, and my PSA at the time was 0.8. And the written report was that there were some suspicious areas around the prostate, but not definitive. And mine was 0.8. So that's why I think I mentioned to you, I'm trying to get into a trial. I'm on a waiting list for a trial with the NIH for another type of PSMA scan called F18 DCF PYL, which is supposed to be the most sensitive available at the moment, but only through this clinical trial. Now, I would differ in opinion from Peter on one count where maybe he was referring to when they would do salvage radiation years ago. Maybe they waited up to 2.0 PSA, but I had just read in the 2019 Prostate Cancer Foundation patient guide, which, by the way, I recommend to anybody to read, where they said salvage radiation therapy should be done between PSA 0.2 and 0.5, and that benefit trails off beyond that point.
Ooh.
So that's a tough choice for you to make. You'd have to make it quickly if you wanted salvage radiation therapy.
And this is the genesis of the call. It's this conflict, of where do you pull the trigger on all of this? It's I absolutely get that you want to wait and get definitive reads on the technology that's out there. And further to this, I mean, what are the pros or the cons of going the traditional sense, the traditional MRI and PET scan? I mean, we've got some state-of-the-art equipment now, which has a better read, but what is that? Does it mean that the older variations and versions of these scans are not accurate or trustworthy? What is? Because they're covered by insurance, but if they're not going to read half of what's out there, they're kind of useless to me.
Well, it's state of the art at the time. There's not much anybody can do about it.
Yeah. But you know what you mentioned, Len, is kind of that inner conflict that I'm going through. Of, you know, there's a part of me then, you know, of my makeup that just wants to get this as soon as possible and not wait, not you know, it's there, it's obvious. And if there's this super machine that's going to spot something that nothing else can, and therefore, you know, pick it apart through radiation or what have you, before it gets worse, then that's the way I want to go. But if you know, then when I look at your chart and it says that a third of the time it won't even, you know, register, you know, you got to go, okay, so now what? You know, do I give it another month or two and wait till I climb a bit and go back in? So that's for my.
So Rich, you may be, and again, I want to toss this one out and see what other people think. But you may be a great candidate for salvage radiation. I mean, we do know that the earlier you go into your salvage radiation, the more effective it is. There have been studies that have been done, and it isn't smart to hang around if you're going to consider salvage radiation. And you know, the salvage radiation for you would probably require hormone therapy for a period of time, maybe 18 months, 2 years, and radiation of the pelvic girdle. And you know, that may be enough to nail the disease. And it's certainly a discussion that you should be having with Dr. Liao. I mean, what do other people think about the opportunity for salvage radiation if you have it?
Well, that's what I did with the Gleason 9, and it's pretty standard drill. A lot of people do that, go with salvage radiation, because the thinking is that if it's spreading, it's probably in the prostate bed,
Right.
and lymph node area and so forth. So that's where they radiate in the pelvic girdle and so forth, as Rick just mentioned. You know, with the Gleason 9, you got to be, and you're 58, so you pick this up at about 55 or so.
Yeah.
You got to be prepared. I mean, I don't want to, you know, I don't want to disillusion. I don't want to make you get scared or anything. But with Gleason 9s, most of us, you know, have come to the conclusion that we're going to be looking over our shoulder for the rest of our lives. Now, that said, I plan on living for a long time. I'm 71. I've gone through, you know, prostatectomy, IMRT, and now I've just done proton beam to my metastatic lymph nodes. But I'm going to be around a long time. I'm going to just do monthly PSA checks, and I'll be able to manage this. But I know that it's my system. I know that it's on, you know, that it'll pop back up at some point, and you just got to be diligent. And so you might want to do salvage radiation, and then maybe you'll get a couple of years out of that before it pops up its head again.
Or even longer, right? I mean, the doubling time is what bothers me, right? I mean, you don't want to ignore a 1 month doubling time, no matter the number, really. Mine ended up going from, oh, we're going to cure him, and well, you know, not really, because it was Gleason 9, just like the last person said. But let's try the surgery to metastatic to my lungs and bones, all in a period of 4 years. So what I've learned after reading all this stuff is, you know, they'll practice all these new techniques on the castrate resistant and near dead folks, because they're the ones you can experiment on, find a benefit, and then move them up earlier. And in every single case, whether it's the drugs or what chemo or whatever, they're 4 times as effective when done earlier than later.
Okay.
I wouldn't wait to do something.
I'm with you. I'm with you on that. It's just throwing this out there. Are there any Gleason 9s that are ever eradicated? I mean, does that exist, or is it just because, you know, I'm resigned to the fact that, you know, this is like you mentioned earlier, something that's always going to be over your shoulder, something that is going to be with you right to the finish line, and you just got to keep being ahead of it. And that, that's the game plan here. But does it ever just shut down and shut off?
I think that's a question you would have to ask somebody like Bobby Liao. I think that, and this is just my gut speaking, I think that there's probably a small percentage of men, depending on how quickly they get treated and where they get treated, that may get durable remission from salvage radiation. I don't think it's the norm, but I don't think it's out of the question. I mean, you can hold out the hope, but I think the others have said, and if it were me, I'm not sure I would be worrying too much about where exactly the cancer is. The likelihood is that if it's recurred somewhere, it's most likely in that pelvic girdle, and that's what they're going to radiate anyway. So
yes.
The likelihood that it is gone beyond that is less, and that's one of the questions you've got to ask Dr. Liao. How likely might it be that it's further away, and should we be looking for it further away, or should we just be going for some hormone therapy right now together with salvage radiation, the pelvic girdle, and hope that nails it, or as Joe says, it gets it for a good period of time, and then we worry about it if and when it comes back. But I think that you can hold out some degree of hope. I don't know. Anybody else have an opinion on that?
Well, it's the $1 million question. Is Gleason 9 curable? I think most docs would give you a low percentage. It's possible, sure, but the odds aren't good. So, and as several folks have pointed out, your doubling time is pretty aggressive, so the cancer is probably pretty aggressive. Not sure what would be gained by, I guess you could get the Axumin scan just to hopefully rule out the fact that there is no spread to the bone, in which case you wouldn't even want to bother with salvage radiation therapy. So let's say you do the Axumin scan, it either shows something in the prostate or pelvic girdle, but nowhere else. Then at least salvage radiation therapy is a good option for you.
Okay.
Yeah.
Yeah, that's where I'm going with this. Prior to the call and all of your great, feedback and all of this is, and the fact that it is something that'll be out of pocket. I'm leaning towards that. I want to rule out anything, beyond, the localized area, or at the very least, if something is beyond it, I just want to be ahead of it. That okay, we spotted it and we got ahead of it. So that's where I'm heading in this direction.
So here's one thing that you could do, Rich. If you haven't done it already, have you run the nomograms on the Memorial Sloan Kettering site?
I haven't, no.
Okay, so that's something that you should do, and I can't. There's no point in putting the URL in the chat box. I know you're on the telephone, but if you go, I can give you the URL. It's mskcc.org/nomograms, NOMOGRAMS/prostate. And one of their nomograms is for salvage radiation therapy, and it will predict the likelihood that the cancer will recur after you've done salvage radiation. and how likely it is that the salvage radiation will be successful. So if you run that and you put in all your information based on the database that the nomogram is based on at Memorial Sloan Kettering, which is several thousand men, it'll give you an idea with a Gleason 9 whether anybody gets a durable remission or not. And I suspect there will be a small percentage of men that do get durable remission, and you can put your numbers in and see the likelihood. Now, I haven't run this one for a while, so I don't remember the details of it, but take a look at it. Let us know. Run, after the call, run it and see what it says.
I'll do that. I will do that.
I'll read to you. I'm looking at the site here. I'll read to you. It says, our salvage radiation therapy nomogram predicts whether a recurrence of prostate cancer after radical prostatectomy can be treated successfully with salvage radiation therapy, EBRT, given after the prostate cancer returns. It calculates the probability that the cancer will be controlled and PSA level undetectable 6 years after salvage therapy. You can use this nomogram for applicable results if radical prostatectomy serum PSA level was at first undetectable and then rose steadily, indicating a recurrence. So, this is exactly your situation. And if you put in your information that it asks you for, it'll give you an idea. It'll answer your question about, can G9 be, can you have any hope with the G9 that you'll get a durable remission? And I'm sure it's going to be a small percentage, but I'm sure it's going to be, it's not going to be zero that fail.
Right. Yep.
Rich, did they run a decipher test on your tumor tissue after prostatectomy?
I'll tell you, let me tell you what happened. There's kind of a backstory to this, and I'll keep it brief. But alluding to what Rick mentioned earlier with the study, I had a genome study done, and Liao and Tawari, and I was brought in to a conference room full of researchers and other clinicians a couple of months ago, based on this information, Rick, that you have, the study that I went through, and it was essentially, the takeaway from it was, look, we tested your tumor, and you're approved. It's something you can have, quote unquote, in your back pocket. Is this, there's traditional therapy, which is the hormone and radiation. However, there's these other drugs that are available that fight other types of cancers, which, if given to you, would likely show similar, would have the same benefits, so to speak. Like in a crude sense, something that would cure a, breast cancer, or treat a breast cancer, I should say, victim, would be used on me for my specific tumor and cancer, and they would derive some benefit from that as something I should consider down the road, above and beyond the traditional treatments that are offered. And that's the essence of what this panel did. They brought me in for this, and I do need to look more at that report and get more information. But again, it's the secondary, or the treatment, beyond what I would typically do initially. It's just something to have in your back pocket.
Yeah. Right.
I
Go ahead.
No, I'm just, guys, I appreciate it. I didn't want to dominate your conversation here. It's just, it's mainly a lot of anxiety, as you guys know. It's, I'm one of you, like so many, I'm the guy in perfect health that you is basically told, oh, you got this, and you're thunderstruck by it. It's like, how can this be?
Well,
Um,
Rich, you've given me the perfect segue to ask Mr. Jackson to say a few words about the call on Thursday night. Mr. Jackson,
Well,
are you there?
oh, I don't know. He'll wake up here momentarily.
Okay, give him a
Rich,
nudge.
we've got
Ready yet?
Rich, we've got a call that's on the third Thursday of every month, 8 p.m. Same time and same connection as this call, and it deals with the emotional side of having prostate cancer, or actually of any cancer. The fear, the unknown, the depression, the anxiety, and everybody on the call, it's a men's only call. So there is no, we don't have to watch our language. We prefer it stay somewhat medical, but what keeps us up at night, what wakes us up, what doesn't let us sleep, what irritates us, what makes our tempers short and our fuses always burning. And it's a chance to just relax, let your hair down, and kind of say whatever you think, but you're discussing it with people just like here. I'm also Gleason 9. But you're discussing it with people that have cancer, that have dealt with how they handled things. And we'd be more than happy to have you, as far as maybe somebody can give you some pointers on the anxiety, how they've dealt with it, the depression, there's times I've been scared shitless. But those are the things that we kick around on that call. We're non-technical. Again, it's peer-to-peer, but we'd love to have you. It's this coming Thursday night, same time, same connection, same phone number, and you can join us on with your computer or the telephone.
Sounds good. Thank you for that offer.
All right. Well, look, is it before we move on and go around who's here tonight? Is there anybody that would like to add anything else to Rich before we move along?
I would, Rick. So, Rich, I just took a quick look at IDH1 mutation. By the way, is it germline or somatic?
We don't know.
Oh, we don't know. Okay. So it's said that IDH1 confers radiosensitivity to the cells containing the mutation. Now, if it's a somatic mutation, that's good news for radiotherapy, for salvage therapy. If it's germline, which means all of your cells will have this increased sensitivity to radiation, that's a double-edged sword, because it could mean you'd have damage to healthy tissues, non-cancerous tissue. So all I'm saying is discuss that with Dr. Liao.
Okay.
Just get his take on that.
Will do.
That's a great pickup.
And one other thing you could do, you could request.
Hold on a second, Peter.
Tissue.
I'll come back to you. I just want to comment on what Len just said. That is a great pickup, Len, because we have people like Professor Bill, for example, who has suffered a fair amount of radiation damage because they had a germline mutation. And so what that would mean is that they would have to, probably through Ambry, I don't know if IDH is on, I'll look as we're talking, but I don't know if IDH1 is on the color panel. But I'm certain it's going to be on one of the Ambry panels. And what they would need to do is to just do a germline inherited test for you to see if it was there. And if it was there, then you'd need to get into a discussion with the docs as to how that might impact you. But it's a really good point. When are you seeing Bobby Liao again this week?
On Monday.
Monday. So, well, yeah, definitely add that. Definitely add that to your list. Peter, go ahead. Sorry.
Yeah, one simple, inexpensive thing that's covered by insurance that you could do is request that they have a decipher test run on you. It's done by Genomics DX, and they'll know about this, and it just tells you your percentage odds of metastasis after where you are in terms of risk after your prostatectomy, whether you're high risk, low risk for metastasis, what the percentages are. It actually gives you a readout from looking at the tumor tissue. So that's pretty standard thing to do, and you can request that.
Got it. Okay.
So
the only thing I would add, just one idea that although the anxiety's bad, everything I've seen is sooner is better. And it just makes sense if something's growing, that the more you can kill, the sooner, the longer the time it's not taken over.
Right. That's how I feel exactly.
And Rich, the IDH1 is not on the colored panel, so you would have to do an Ambry test, which has to be ordered by your doc.
Okay.
And you know what? You might want to do me a favor and mention that to your cousin, because they may be looking for the same mutation since you carry it, and neither CCND1 nor IDH1 is on that color panel. So they'd have to be looking for it through an Ambry panel, which has to be ordered by the doc. Okay. We're going to move along, and hopefully we'll be talking to you often. As you know, we meet weekly, but I know that Tuesdays are not great for you because you're on your way home. I didn't ask what part of Tri-State do you live in?
I'm from Queens originally. I live in New Jersey and I work in the Trade Center.
Oh, right. Okay. Okay. Yeah. So you take the PATH train?
I do. Yep.
Okay. Okay. And what part of Jersey are you?
I'm in Maplewood for the last 10 years.
Yeah, yeah. I know where that is.
Leafy little suburb. It's for city people that don't want to go to the burbs. That's what we do here.
I see. I see. Okay. All right. So and then at some point we're gonna get you hooked into Donna Wilson and her exercise class, but that's to come.
Okay.
Okay. That's the charge that I'm giving to Len and to Richard Foodie to get you involved in that class at some point if we can. Okay.
Right.
I'm going to run down the list. Let me just make sure that no one else has joined us that I don't have on my list. Oh, Larry Fish, there's somebody has joined us. I didn't have Larry down. Okay, so let me go down the list. Jake, anything that you would like to discuss tonight?
Only if we have time. We haven't talked about my PSA for a while.
Okay, we have time. Mr. Correa, anything that you'd like to talk about tonight?
I'm good, Rick. Just learning and listening.
Okay. And staying dry, I hope.
For the time being.
Yeah. No golf. You better take your. We
got wiped out this week, both Monday and Thursday.
Oh yeah. Oh yeah. You got. I can see. Mr. Jackson, anything for you tonight?
Just have a short question with probably a long answer.
Okay. Joe, anything you'd like to talk about tonight?
Well, just quickly, I'd say I learned from you guys and now have my germline color test out for analysis, as well as my foundation medicine somatic test. So I'll let you know.
Okay, well, we'll just come back to you and talk to you about that momentarily. Len, anything for you?
No, Rick, no thanks.
Okay. Paul Frieda, anything for you?
No, not tonight. I'm good.
Okay. Les, anything that you'd like to talk about tonight?
Not tonight, thanks.
Okay. John Appler, anything for you?
I'm good, Rick. Thank you.
Okay. Sylvester, anything you'd like to talk about tonight?
No, thank you.
Okay. Ken Anderson, anything for you tonight?
No, thank you, Rick.
Sure. Oh, God, geez. You guys somebody's going to have to come up with something here. Peter, anything you'd like to speak about tonight?
No, I don't think I have anything either.
Oh, my goodness. And I know
Come on,
Larry
guys.
Fish.
We're not going to spend all night on me. Come on.
Well, I don't know. I don't know. Larry Fish, do you have anything? Mr. Fish, are you there?
He's muted.
I know, I can see. He's probably stepped away. Well, it's okay. Jake can hope that maybe Larry has something. But he'll be back. He'll be back. I'm watching. He'll be back. All right, Jake, we're kicking off with you, man.
All right. Well, I'm getting another test on Friday, but my last one, my PSA had gone up to 4.5, which was only 0.3. It's been going up since June of last year. It had been holding steady at 0.7, and then it started going up precipitously. But this last time it went up from 4.2 to 4.5, which I was actually happy with. It wasn't quite as, rapid a rise as it had been doing before. So I had actually called my doctor and asked her, should I refill my enzlautamide? And she said, yeah, stick with it. And then, like I said, it did go up. It's the way I calculate it is like a 10-month doubling period. So compared to, I don't know why, that makes no sense. Why it went from, a doubling time of a month or two, and then kind of been basically leveling off. I don't have any explanation for that.
So Jake, I have on my notes here 11/18 that you're at 2.2. Is that right?
Hang on, let me switch to my fancy Excel spreadsheet if I can here. 11/21 it was 2.9.
11/21 it was 2.9. Okay.
And then 12 then December it was 4.2. And in January it was 4.5.
So it really jumped between the end of January and December is when the big jump came.
Yeah, 44%.
And
then a level off again. 4.2 to 4.5 to my mind is kind of
a
little bit level.
And what's your thinking?
I don't know. I really don't know. It doesn't make sense to me, that it would rise precipitously and then suddenly kind of level off. Maybe it was a fluke. Maybe it was, an error in the lab. I don't know. Probably the best measure will be I'll find out when I get my blood tested this Friday. But other than that, I really don't have any thoughts.
So, I mean, what about your thoughts on treatment?
Well, I had discussed it with my oncologist, and I know I've mentioned that on here before. Probably the next thing we do will be Zytiga, even though it's a small percentage of the people who respond. She made the point before. She says, "Well, you've always been a good responder," and she's right. I always have, to the treatments that I've had so far. So she thinks it may work for me for at least for a while. And then after that, I don't know if apalutamide might be a consideration, if it would be approved for somebody in my situation, or if I need to go straight to chemo.
So you're in long-term ADT and it's going up?
Yes, I've been on I've been on Lupron since June of 2012. And then lately, and for about the last 2 years, I've been on Xtandi.
Okay.
Sorry, I should have mentioned that.
Well, that's okay.
On this call, Joe, it's kind of assumed that anybody that's taken Xtandi or Zytiga generally is assumed.
Yeah, right. I just wanted to make sure I understood. Right.
There are exceptions, but generally.
Well, not very many calls like this is the other way to say it.
Huh?
There are not very many calls like this is the other way to say it. But yes, right.
I want to throw it out, but I want to know if you've got any questions you'd like to ask the guys for them to consider before I throw it out.
I'm looking for suggestions.
Okay.
I think I'm on the right track. I mean, I have Gleason 8, stage 4. It's in my bones. It's in my hips. It's in my sacrum. It's in my iliac wings. In my spine. So I know it's not curable, but we've been holding it steady for 6 years now, almost 7. It'll be 7 years in June. But I'm running out of options other than Zytiga and maybe apalutamide. I'd like to see if there's any thoughts on that. If that's even Len might know about the approvals for that.
Yeah, actually, Jake, technically, you would not qualify because apalutamide has only been approved for non-metastatic CRPC.
Right. That's what I thought, but I wasn't sure.
Actually, oh, you're right. But they just released the trial showing that it was effective for metastatic castrate sensitive, but even that doesn't help, Jake.
Yeah.
Well, that's a question. Am I castrate sensitive or not? I mean, if I stop the Lupron and Xtandi, my PSA would go through the roof. Would it not?
Yeah, well, but if you were castrate sensitive, your PSA wouldn't be rising.
Right. At all.
I mean, I guess it's risen enough to say, that. But.
Jake, don't forget to talk to your doctor about the indomethacyn.
Yeah. I actually looked into that a little bit more, and it's no more dangerous, Len. You said last time that I wasn't interested. It wasn't that I wasn't interested. I was just worried about the heart issues and everything. But I mean, I take ibuprofen, and that has heart issues. Indomethacyn is no different really than ibuprofen.
That's right. Same basic class of drug.
So I could probably just take that over the counter, right?
No, I don't think it's available over the counter. You probably would need a script. Okay. It has more side effects. I can't recall exactly which. Has more side effects than the common over-the-counter NSAIDs like ibuprofen.
Right.
So it could be that the manufacturer never thought it would be competitive, let's say, to put it out OTC. So you're probably going to need a script for it. Nevertheless, when you compare it to something like chemotherapy, it's a much safer drug.
Oh, I know. I'm one of those ABC guys. I really don't want to do chemo.
Yeah.
I see what it did to my sister-in-law and how she's had reactions to it, and I see what it's done to Bill, and I really don't want to do that. I'm willing to try anything else.
I think people have had decent results, right? Of just, with me, they went Zytiga first, but they've always said, later on, maybe we'll flip it and do enzalutamide when the Zytiga is not helping. It seems like an obvious question would be, why not mix up, switch out the medicine, stay on the ADT and switch to Zytiga.
Well, that's my thinking, Joe.
Haven't they done some research about by switching and going back again to enzalutamide, you can resensitize yourself to it? I think I've read something about that. I don't know anybody who's done it, but I thought you can get resensitized to it.
From going from Xtandi to Zytiga and then back to Xtandi again?
Yes.
Well,
so I'm reading something about that. I don't know
I think you're
how
right.
accurate it is.
I don't know if people went on Zytiga in the interim, but I think there was some studies that show that you could go back on Xtandi several months after you come off of it, and you might get a response.
Oh, kind of like stopping Casedex for a while and then going back on it again.
Yeah, but with Casedex, I don't know if you get anything from going back on it. But
yeah, that's an interesting thought. I'd be willing to try that.
Yeah, but you see, people usually do something in the interim, and I don't know whether abiraterone would work, or it might be for people that go on chemo on the interim and then go back onto the Xtandi afterwards.
In terms of chemo, I got my chemo about 6 months after getting diagnosed, and it's my understanding that the earlier the better. I'm not trying to encourage you to run out and get chemo because it sucks, but they were showing numbers. I think it was Stampede and Charted both were showing these numbers, like instead of being offered it late in life and you get 4 months from going through hell, if you do it sooner, you get 16, 17 months for the same amount of hassle.
Yeah, I mean, I always say that the numbers seem to show that the chemo gives you the biggest bang for your buck. And there are guys that weather that chemo really, really well. And there are others who have difficulty with it. And, you mentioned Professor Bill. Bill didn't have too bad a time. I mean, he did fine through his first 3.
Right.
And he got hammered on his 4th. And then after his 5th, he was pretty much okay again. And that's fairly typical. But I tend to agree with Joe that that you do get the biggest bang for your buck. Now there was a study that came out. I mentioned it in the email I sent around earlier this week. Study that came out showing that chemotherapy did not show any effect for people with high-risk disease early in the disease process. That was a discussion I remember I had with my doctor back in 2007. I was willing to do chemo way back then. And he said, we just don't think that it's beneficial at your level. And there's a study that's come out this week.
But that's pretty much at odds with this consistent pattern of moving things earlier and getting 4 times the result. Like they really did show, 6 rounds of docetaxel when you're castrate sensitive versus castrate resistant was 4 times the result.
Yeah,
so
but remember
which one's right.
And you're right, Joe. But the study this week that came out was for men that had no metastasis.
Okay.
The studies that we're looking, that you're referencing, that I'm referencing, these men all had some degree of metastasis.
Understood.
And so what they're really saying, you see, you could have to compare it to the breast cancer model. Whereas if you get diagnosed with stage 3 or stage 4 breast cancer, they'll do surgery, radiation, and chemotherapy up front. And they don't do that in prostate cancer, even with, with stage 3. And what they're saying is there doesn't seem to be a reason to do it because we still don't have enough evidence to show it's worthwhile. Although, I think they mentioned this study was quite an old study. It's because it takes a while for these studies to cure. You got to do the study, then you got to wait a number of years and all of the rest of it. But anyway, that was the study that came out. But the bottom line, I think, is yes, chemo gives you the biggest bang for your buck, and for some people, it does have the worst side effects. For some people.
If you do ever do it, I recommend sort of demanding the on-pro thingy on your arm up front. My insurance company said, "Oh no, he doesn't need that," and I went through 2 rounds, and then $55,000 later and 4 nights in the hospital, they decided, well, yeah, maybe he can have the on-pro.
Yeah,
it helps.
Yeah,
is that the same as Neulasta?
Yeah, Neulasta.
Right. Dennis Correa knows about that, right, Dennis?
Yeah, that's the same thing. My when I got my initial diagnosis being metastatic bone and so forth, and Gleason 9, we took the latest study results with the chemo, docetaxel with Lupron right away as soon as possible. And I did after I believe my 4th session on the chemo, I crashed with the white blood cells and went in and hospital for 5 days, and they took care of it. Then they put me on the Neulasta the day after shot after that.
Yeah.
And got through the rest. They actually, the other thing they did is they actually reduced the dose a little bit. And but I got through the rest of the series of that. And that worked good. But I think the Zytiga is probably your next best choice at this point in time.
Yeah.
And
I think so too, Dennis.
that other study that Rick recently set out, the lutetium 177, I believe.
Yeah.
That looked very promising. I mean, that does have some potential side effects with it, but I don't know. I think they're going to be doing more trials on that too. Rick, is that?
Yeah, they are.
That might be an option.
Yeah.
That's still down the road.
Yeah, that's down the road, I think. I think the Zytiga is next in line for you.
Well, that's what I think too. I'm gonna again, I'm gonna wait till I see what my PSA is after this next test, and if it's still within, within some, if it hasn't gone up too much, I'll probably stick with the Xtandi, get a few more months out of that, then go to the Zytiga, and then who knows, maybe by then lutetium will be approved. I doubt that, but and I'm going to definitely talk to the doctor about the what's it called again, Len? Indomethacyn?
Yeah, you got it.
Okay. IND, right?
IND, indomethacyn, CIN at the end.
Yeah,
it actually inhibits an enzyme that gets upregulated or more active in cancer cells when they become resistant not only to enzlautamide, but also to Zytiga. So what happens is when this enzyme gets activated, the cells produce their own androgens internally.
Okay.
So the indomethacyn blocks that enzyme.
So it's taken in conjunction with
Yes.
Xtandi?
Yes, it has to be taken together.
So what is the net effect? It makes the Xtandi more.
It resensitizes the cells to Xtandi because the reason they became resistant, according to the hypothesis, is that this enzyme, despite the fact that you're taking enzlautamide, the enzyme causes the cancer cell to produce its own androgens, its own testosterone.
Right. Okay.
So they block that enzyme, and now the cell is once more sensitive to enzlautamide. And apparently Zytiga.
And Len, was this, I don't remember the discussion on this before. Is this from a study or from a paper or that you read or what?
Yeah, here, let me put the link. This is from a study where they give the rationale why they're starting a clinical trial with indomethacyn and enzlautamide. I'll put it in the chat box here.
Thanks, Len. Thanks. Okay.
I'll send it to everyone.
Thank you. Yeah, we'll definitely take it.
Sure.
And Jake, do me a favor and please raise with your doc this issue about pain management.
About what? Oh, pain management?
Yes.
Okay. I do take an oxycodone every night to sleep. And, but, you know, and I'm trying to, she gave me a prescription that I could take up to 2 every 6 hours as needed. And I really have been trying my best to stay away from that. And I take enough drugs now for cholesterol and triglycerides and everything else. So I do have medicine for it. I just don't want to double up on it or triple up on it. So.
No, but you know, the issue is that you can't get behind the pain. And when it becomes troublesome so that you don't want to go out because you're worried about the pain, it's getting in the way of your life. And you've got to you just got to take that into account.
Yeah. Okay.
Right.
You know me, I don't like to go out anyway, but
we know that.
It almost killed me today to go to the Jiffy Lube.
It's nice to see you reclining, you know, that's pretty relaxed. That's cool.
Well, that's why Rick and I were talking earlier, Joe. That's one of the reasons I do recline. I'm not trying to be rude or anything, but I feel I'm more comfortable laying on my side than I am sitting on my butt.
I understand.
My hands in my butt and in my spine. So I'm not trying to be rude or impolite. It works for me though. So.
Okay. All right. Well, we've given you, when are you seeing your lady?
Friday.
So we've given you a few questions. Write them down, hand her a copy, get the questions answered. You know.
Yeah.
All right.
Thank you, gentlemen. Thank you. Appreciate it. Oh, and Rick, one other thing. I talked to you off on the phone one time about diarrhea.
Yes.
And you suggested cutting back on my metformin, and it worked.
Oh, good.
Yeah. I mean, I'm not saying I'll never have it again, and I do wear a diaper when I go out, but just in case. But since then, by cutting the metformin in half, or the dosage in half, I have not had any. So. For what it's worth, anybody out there that takes metformin is having problems with diarrhea, try cutting your dosage down a little bit.
Right, 500. I mean, I do know that many men who go on metformin start with 500 rather than 1,000, and then they work up if they can, and if they cannot, they stay at 500, and that's the reason why.
Right.
So I was just passing that knowledge on to Jake, and I'm delighted that it's making your life easier, Jake. Great.
Yeah, it is. Now I'm back to being constipated again, and I prefer that.
Just up the dose of that metformin.
Well, you're right. Yeah, no.
Well, that's probably opiates.
I'm sorry, Len. What?
The constipation is probably from the opiates.
Yes, correct.
I thought you were taking metformin for years.
I have been.
And just all of a sudden started causing diarrhea, huh?
Apparently, yeah. And I couldn't figure it out. You know, I didn't know what it was because I hadn't really changed my medicines. You know, but then Rick said, "Well, try cutting it in half." He said he pointed out that it didn't make sense that having been on it for so long, it would suddenly start causing a problem. But that's why we log on to this call, because he usually has some smart answers. And this time it worked. This time he was right.
Go, Rick.
I've got a suggestion for you on constipation. I've had constipation problems. And, I take Bran and Metamucil and things like that. But I recently discovered a different way to handle it. I lived in Asia for 11 years, and there you don't use toilet paper because the plumbing systems are inadequate, and so everybody there's a hose that sits next to every toilet, and you just spray yourself. And so the long and the short of it is what I've done is I pretty much give myself an enema every other day, and just a little bit comes out, and then I don't get constipated anymore. Now, some people have warned me that I'd be putting bacteria up into my system, and that's not a good idea, but I'm not convinced that it's that dangerous, and I haven't had any doctor to tell me that that's not, that's a problem. And you can, at any Home Depot, you can get a little attachment that attaches to your, to your toilet. And it seems like an awfully natural way to handle it. You get a little bit out all the time. You don't give your body a chance to accumulate that big bulge that won't come out anymore. And so it's just a suggestion for you.
Well, thank you, Paul. That one's going to take some thinking about. I don't know.
That actually feels good. I mean, you just squirt it up there. When it, you got an awful lot up there, and you can't even tell whether it's going to come out or not. But if you just do it every other day, a little bit will come out. And I haven't had any constipation for a while now.
Okay. Well.
Anyway, talk to your doctor about the bacteria. Criticism, and then make a decision for yourself.
All right. You're talking essentially like the European bidet.
Yeah. Except the bidet sort of squirts and cleans you. This is just a full-blown hose that you stick up there, and right. So it's much more, it's stronger than but of course you can control the strength of the spray, and it's just a different way to handle it. We don't in America. Most everybody uses toilet paper, but I haven't used toilet paper in 15 years. So.
Paul, basically, are you talking about like a fleet enema?
No, you don't. There's no. When I say enema, everybody associates that little suppository. You don't. No, you're just squirting water up into the bowel. And there's usually some stuff that that's made its way down to the to a certain point, and then it just flushes out. But it's usually just a little bit. But this prevents the buildup where you end up with that huge bulge that just won't come out. And it's just and anybody's had constipation know how agonizing that is. So but anyway, all you're doing is squirting water up your rectum. That's all. There's no medicine, no suppository or anything like that.
All right, guys. I think
thank you, Paul, but enough for me.
Okay.
I think we're going to move along. I know we don't have a lot of people who want to talk, but probably it's time. What do you think, Jake?
About moving on? Yes.
Yes. Okay. Mr. Jackson, the man with the short question and the long answer. Please go ahead.
Okay, the short question is, how does it progress from Gleason score of 3+3 to 3+4, and then 4+4? Because I recall hearing somewhere that they didn't progress.
Right.
That it wouldn't turn from a 3.3 to a 3.4, from a 3.4 to a 4.4, from a 4.4 to a 5.4. What did I hear incorrectly?
No.
Does it just magically appear that I had a 5+4?
So here is my
I'm just curious.
Understanding of this, and then I don't know, maybe Len can help out.
Well, I've got something to say.
Or Paul may want to say something. That, and I've verified this a number of times with different specialty doctors, but the cancer cells do not change. So a 3 always remains a 3, and a 4 always remains a 4. So a cancer cell that has the appearance of a 3, when that cell divides, it stays a 3. It doesn't divide and become a 4. It stays as it is. But there are some cells that are sufficiently, what's the word? Indeterminable, unidentifiable. They don't have good shape. There's a technical word for that. It's not coming to me.
Undifferentiated.
Undifferentiated. Thank you, Joe.
Sadly, I know that one.
They are sufficiently undifferentiated that when you see them in the beginning, they're a 4. And when they're even more amorphous, they're a 5. And those 5s stay 5s. And the 4s stay 4s. So depending on how the cancer has developed, it can develop at different rates of different stages of disease. It can just emerge as a more aggressive cancer. It never was an unaggressive cancer. Some people just they develop aggressive cancer, and it's always aggressive cancer. It wasn't the 3 in the first place. It came out as a 4. Imagine it being born as an aggressive type of cancer, or as a 5, a very aggressive type of cancer.
Okay.
So
you're talking about after a biopsy where they find, we thought you only had a 3.3, and then after a prostatectomy, it turned out to be worse, right? That's
well, I mean, I'm not talking about how they find it and how they determine it. I'm talking about just the biology of cancer. I mean, you could always have a 5. We might not know it, and the only way we'd ever find that you had some 5 in there was because we removed your prostate and we sliced it up. Then we'd know you had 5.
So there is no progression. It either starts life as a 3 and it lives forever as a 3 and it dies as a 3,
right?
Or it starts as a 4,
right?
Or it starts as a 5. It just magically appears as a 5.
Right.
Okay.
So if it magically appears as a 5, you have aggressive cancer. However, it got to be cancer in the first place. These cells dividing rapidly and growing out of control. Sometimes when we see them, they're an unaggressive cancer, and sometimes when we see them, they're a very aggressive cancer. And what the pathologist can do is look at those cells and say it's an aggressive, or it's a fairly aggressive, or it's an intermediate, or it's an unaggressive cancer.
But
depending on how differentiated those cells look.
But the pathologist is looking at it as a slice in time. Right this second, that cell is a 4.
Yes.
This, when it was cut out and handed to me, it was a 4.
Yes.
So what you're telling me is it was never a 3.
Correct. That's my understanding. That's what I've always been told.
Okay.
Now you could have 3. You could have cells
as a separate issue, in a separate location. Okay.
Right.
Right.
But it just.
But pathologists make mistakes. Pathologists can miss things, and it can be misdiagnosed. So there might be 4 hidden in there, and it was never biopsied, or 5 even, and never biopsied. So it gives the appearance that something's turning into something else, but it's just not an accurate pathology report.
No, then what I'm trying to get my head around is that a normal prostate cell in my body, or in any of our bodies, woke up one morning and said, I'm going to be a 5.
No, it's not likely.
Then how did it get to be a 5?
Well,
If
there's
it
some
didn't progress from a
sensitivity
3 to a
in
4
the
and
estimation.
a 4 to 5?
It got to be a 5 because there was some irregularity in the way that that cell divided, maybe a gene irregularity, or I don't know what else. We need Professor Bill to explain it to us. And maybe if you went back and listened to the Cancer Genetics 101 again, you might be able to pick up, listening specifically, you might be able to figure it out from that. But somewhere along the line, those cells became abnormal.
Okay.
And they became abnormal in a very aggressive way, and they became 5s. They could have become abnormal in a less aggressive way and become 3s, and not spread very much.
Let me ask a question.
Hold on before you do. Let me just. I'll come back to you, Jake. But let me come back to Rich and see if he wants to follow up on that.
Well, no, that was my simple question with a really long answer. Was how does it? Because what it sounds like is it just wakes up one morning and decides through, as it's dividing, that it's a 4, it's a 3, it's a 5, and there is no, the 3s get worse and, you know, become undifferentiated more and become a 4. As they divide and become worse.
No, the 3s don't get undifferentiated more. The 3s always stay 3s. So some cells, when they see, what I cannot answer, I don't know, Len may have a better idea on this. What I cannot answer is, why does a cell become cancerous in the first place? What is it in the cell cycle that takes it from being a normal, healthy cell to becoming a cancerous cell which has uncontrollable division?
Well, it goes a little bit on the stupid side, but okay.
Well, I'll take a stab at that, Rick. I believe that the general theory is that when a cell becomes cancerous, it's because in the process of replication, let's see, you have a normal cell and the genetic code has to be transcribed so that it could be duplicated. Now, mistakes can be made, and they are made. Mistakes are made when the cell is dividing, and these are called mutations. And if the mutation is one that affects the cell's function only partially, then you have a low-grade cancer. In the case of prostate cancer, maybe a 3. If it's a serious mutation or multiple mutations while the cell is dividing, then you have a more bizarrely undifferentiated cell, and you have a higher grade, a 4 or a 5. Does that make sense?
Mm-hmm. Yeah. To me it does, but
yeah.
Yeah.
As a matter of fact, it was about a year ago, they did a study where, you know, they tried to answer the question, why do people get cancer? The investigators concluded that in 70% of the cases, it's just bad luck. Everyone's cells are constantly dividing. If they divide and replicate faithfully, you're going to have no cancer. If while they're replicating, just bad luck, there's a mistake is made, then you've got cancer. It's all about genetics.
Well, no, I don't disagree with how cancer develops. But what I'm fuzzy about is that the first mutation that develops a 3, what I'm hearing is that it can never become worse than a 3.
That's the general belief, yes.
Right.
Okay.
Can I chime in here? When I first got my first biopsy, I was diagnosed 3-4. Then when I decided to have the prostatectomy, I took the slides from the hospital in Bangkok and brought them to Memorial Sloan Kettering, where I was going to have my prostatectomy. and gave it to their pathology department, and they analyzed it, and they said, no, I'm sorry, you're a 4.3. And then the pathology report after the prostatectomy, they said you're a 4.4. So I don't know that the biology changed, but there's several reasons why, you can get different diagnoses depending on the skill of the people involved. There's subjectivity, I think, in looking at the cells. One doctor may look at the cells and say that's a 3. It's a 3. Oh, gee, it's a 3++. Should I call it a 4 or should I call it a 3? And in that hospital, they like to not have patients get scared, so they'll diagnose 3. Where another hospital say we don't want to take any chances, we'll call it a 4, if under any circumstances. So there's subjectivity involved, as Len said. There's errors involved, and then there's also the issue of how much tissue they had to work with. I mean, when I first you can have a biopsy and they take, I don't know, let's say 15 samples, and they may not have hit the spot where the cancer was, and they say you don't have cancer, but you actually had 4.4 at that time. So there's several reasons why a lab or a doctor can come back with a different, a different number. And like I said, I went from 3.4 to 4.4, 3.4 to 4.3 to 4.4 in my progression.
So that's a slightly different issue to what Rich Jackson is addressing. I mean, Rich Jackson is really talking about the biology and saying, well, if you've got a 4, is it always a 4? If you've got a 3, is it always a 3? Does a 3 become a 4? Does a 3 become a 5? No, it doesn't.
No, I understand that, but Rich,
hold on. Let me finish. The issue that you're talking about is the interpretation of the slide. So what happens is that when a slide is taken and the pathologist looks at it, they look at all of the cancer they see on that particular slide, and they determine how much 3 there is, how much 4 there is, and how much 5 there is. And maybe how much less than 3 there is, but we still tend to call it 3 because we've sort of lost 1 and 2 along the way. And they look and each one of the cells looks different. So it becomes the judgment of the pathologist how much 3, how much 4, how much 5 he's seeing. I mean, we're not talking about how it became a 3 or a 4 or a 5. And we're not saying that if you put that slide away and come back to it a day later, it's going to have changed from a 3.4 to a 4.3. It's just that one pathologist may interpret it as a 3.4, and another pathologist may say, no, I think there's more 4 on the slide than there is 3. The way that it works is that the largest grouping of cells of one type is the first number. The second largest grouping of cells is the second number, and sometimes you'll get a tertiary reported. It's not often, but there are some pathology labs that report a tertiary, and that's the third largest grouping of those cells. So what you're talking about specifically, Paul, Frida, is the judgment of the pathologist in how he sees those cells and what he considers those cells to be.
Right.
That's different from how those cells came to be.
The Bangkok doctor saw something different than the Memorial Sloan Kettering doctor did. But I think the reason I went 4.4 after my prostatectomy is they had a whole lot more tissue to look at. And so they could look for the worst spot, and they found a spot where they thought it was 4.4.
So the question that I'm asking is, how did it become a 4? Not what somebody interpreted, not what somebody looked at.
Right.
How did that 4
become a 4?
Wherever you found it, how did that 4
become a 4? Because
it was born a 4 because it was, the way it recreates itself is more undifferentiated than a 3 or a 5.
That's right. There were more mutations.
Less than a 5.
There were more aberrations. There were more, as Lem pointed out, there were more mistakes in the way that cell divided than the cell that divided that was a 3 or the cell that divided perfectly naturally. And
Rich, think of baby deformities. Remember the thalidomide babies? They were horribly deformed. Those were
Yes.
genetic mutations. And then you could have some kids are born with this 6 fingers. It's not so bad. Think of it that way, if it helps you.
Okay. No, that was the short question with the really long answer. Was
Okay,
where
but
did
good.
the 4
Yeah.
come from? But
And,
okay.
and my little bit of cancer research has said, right, that more mutations, and they're either in the direction of messing up cell death, so they don't die when they're supposed to, or over on the other end, when it's cell splitting, that it grows too fast. So you can mess up either end of the cycle, either have too many replicate or have too few die.
Anyway, and that's the Rich Jackson issue. The Paul Frieder issue is the eye of the pathologist, and it's always puzzled me why in this day and age we're not able in some way, shape, or form to standardize what the pathologist sees and have a hard standard against which we can measure, but evidently not. And that's why people say send them to the Epstein lab, because we trust the eye of the Epstein lab more than we trust the eye of any other lab in this country.
Okay, I'm good. Thank you.
Our pleasure. Good question. Very good question. Paul Frieder, are you good?
Yeah, I'm fine. I just wanted to relate my experience, and you can't take what the doctor says as gospel,
Right.
and it's very unlikely that a 3 morphs or a 4 morphs or a 5 morphs. But I would just suggest from my my long scientific experience that there may be some small percentage chance that it can happen, but it's so small that people really don't think about it. I mean, I don't know that doctors can say absolutely under no circumstances can a 4 become a 5. But it might be like 0.003% chance, that kind of thing.
Well, I've never heard him say that, but you may be right. But I mean, all I can say is if that's the case, then I'd like you, do a little research and see if you can back it up. We'll buy it. But I've never heard him talk about a cell changing into something other than what it was in the first place. It divides.
Well, the overwhelming situation is that they don't,
I mean, at some point, the zeros turned into 3s.
Well, yes, that's right. That's right. You're right. I mean, but whatever. I guess I don't know. I'm getting out of my depth. And where's Professor Bill when we need him? Okay. Actually, had Professor Bill been here, it probably would have been a couple of quick answers, and we would have all said, yes, we understood, but we didn't. And we would have moved on. Right? Okay, Joe, why don't you tell us a little bit about this genetic testing that you're doing?
Well, I'm sorry about missing the last call. I was on a trip to the Czech Republic, which was fun. I got a cancer story there. But yeah, I tuned into your calls a few times here and heard about the Gentleman Project for germline testing, and then talked to my oncologist about the Foundation Medicine for the tumor testing, and they're both out right now, so we'll see what they say.
Okay. So one of the things that I wanted to raise with this is that, and this is very pertinent to the conversation we had with Rich at the beginning of this call, is that sometimes it is necessary to get both the germline and the somatic test done, because that's the only way that you know whether your mutation is inherited or it's not inherited. So, for example, let's take the example of a BRCA mutation, and we have somebody like Professor Bill who has an inherited BRCA mutation, and someone like Len who has a somatic BRCA mutation, meaning that his own body, his own tumor created that mutation. He didn't inherit it from anybody. And it's really important for someone like Len to know what the source of that mutation is. And if all he does is somatic testing, he's not going to know whether there's a likelihood that mutation can get passed on to his offspring, and they may want to know, they may need to know. Now, Ambry has just created Ambry Genetics is a germline inherited testing company. And they have a lot of different panels. They have to be ordered by doctors. It's fairly comprehensive, and you can decide what panels that you're going to get. And they've just cut a deal with Foundation Medicine. I don't even know if it's announced, but I sort of put two and two together when I spoke to them about weeks ago. And they're now able to do a test for PARP, for BRCA, that tells you whether it's germline or whether it's somatic. But it's not such a, this isn't anything particularly new. It's just innovative in the sense that they're really not doing one test, they're doing two tests. So they're testing your tumor, and they're also testing either your saliva or your blood, and they're figuring out whether you have an inherited, and they're checking that against the tumor to see what's in the tumor. And if you don't have an inherited, but you do have something in the tumor, they know it's somatic. Now, you know, if it's inherited, it has to be in the tumor because it's in every single cell in your body. That's the nature of it being inherited. But there are times when we need to know that, and one of those is, for example, with Rich Stevens and IDH1. It's important for Rich to know, is that a germline mutation or is that a somatic mutation? Because if it's a germline mutation, he's going to be more susceptible to radiation damage than if it's just in the tumor itself. So if you're wondering why somebody like Joe is doing both tests, that's the reason why. Now, would it change the treatment? God forbid we found out that I shouldn't even say God forbid, because sometimes it's not a bad thing if you do have one of these mutations, because there are drugs that can address them. But let's say you had a BRCA mutation. The treatment would be the same. It would be a PARP inhibitor, whether you were somatic or whether you were germline. It would still be the same treatment. But really, we need to know because of radiation issues, because of offspring issues.
I've got an 18-year-old son.
Right. Right. Important. It's important. And is there anyone? No, Carl Foreman isn't on the call tonight because, of course, Carl also is germline BRCA. Peter, you want to talk about this a little bit because you've got a couple of germline mutations in there, right?
Yes, I do. And I also have a somatic mutation of BRCA that was discovered. I took 2 independent tests, first one from Ambry for the germline, and then a couple of years later, more recently from Foundation Medicine. I have a question, Rick, that I'm always confused about. It goes back a couple of years ago. You were very insistent that people get tested for somatic mutations on current tumor tissue because you felt that there could be genetic mutations, and perhaps somatic mutations would show up now that weren't there on the original tumor tissue, say from my prostatectomy. Is that still the thought, or is it not really current thought?
No, I mean that is the current thought. That you want the most recent tumor tissue that you can find, but if you can't get it, then you test what you had.
So you could. So theoretically, you could test your original tumor tissue, say from a prostatectomy, could not show something, and then 3 years later, from another sample from some metastasis, could show BRCA or something like that that just appeared over those past 2 or 3 years?
Yes.
Huh. That's interesting.
It mutates in some way to become castrate resistant, right?
Yep. Yeah,
right. I wasn't sure about the actual genetic mutation. Castrate isn't a genetic mutation per se, is it?
Well, it is, I think, because I think that there's a genetic change in the way that the androgen receptors are formed. Is that right, Glenn?
I was just going to say, Rick, that the key word we're looking for here is what is the driver mutation? So you can have a mutation that is of no clinical significance. It's not driving the progression of the cancer. But what they want to identify is the specific driver mutation, that mutation which is causing the cancer to metastasize and progress. Now, how they determine what is the driver mutation and what is just, I think they call it a passenger mutation of no clinical significance, we'd need Professor Bill to chime in on that. But I believe that they do have some means to determine what the driver mutation is. And the driver mutation, my understanding is that it could be both in the primary tumor and the metastatic lesions. Like I have 7 mutations. You know, when I did the genetic testing at Sloan Kettering, they came up with 7 mutations. One of those is probably the driver mutation, but which one? I don't know. I don't know that they know. But it's probably only one of them.
But to answer your question, Peter, yeah, I mean, the way that the disease, the genetic makeup of the disease is constantly changing. And that's why, for example, we see disease as it progresses that becomes more undifferentiated and more like neuroendocrine, small cell. The disease that starts off looking like adenocarcinoma can finish up. I'm thinking of, say, somebody like Neve, God rest his soul, Savage, who definitely had adenocarcinoma in the beginning, but by the end of his disease, his disease was acting like a small cell prostate cancer.
My oncologist, last time I saw him, we discussed this, and he said that, no, it's not just my imagination, but they, at least in his opinion, they're seeing more of this transition to adenocarcinoma, possibly because of the way the supplemental ADT like Zytiga and enzlautamide drive everything completely to zero. Right. Instead of seeing the normal quote unquote, cases since Dr. Huggins, they're seeing different results, which makes sense with different treatments.
Well, that's right. And this is something that UCSF has been pushing probably since, I mean, as long as I can remember going to the research sessions there, that the disease does change, it does morph, it does become less treatable the more advanced it becomes. It becomes more and more like neuroendocrine disease. It didn't start off that way, but it sort of turns into that. So
interesting.
But,
in response to this changed environment from the treatments.
Yes, and exactly, and it's the cancer responding and reacting and adapting to the treatment that is trying to destroy it.
Right.
And that's one of the reasons why schools like UCSF or research centers like UCSF have always been opposed to doing too much too soon altogether, because they say that encourages the disease to morph quicker. So, you get the old Snuffy Myers, and to a lesser extent, prostate cancer, prostate oncology specialists who throw everything at the disease early on. And then you get the Eric Smalls of this world who say, or the Chuck Ryans who say, no, let's milk it as much as we can because we don't want to encourage this disease to become untreatable. Is this making sense to anybody out there, or am I just blabbing? Don't answer that, Jake.
I had one other weird thing going on I ought to mention. For the last 6 weeks, I've had myself, I'm a hypochondriac, right? But I've had myself convinced I've got lymphoma or something because I've had these, I sit here looking at myself on the screen. I got this puffy face and all this stuff under my chin, and did the blood tests, and the lymphocytes and the leukocytes were right for some kind of problem. But I tell my oncologist and my internist, and they're not too interested, and so I'm off to see the dentist. But I've had bad teeth before, and this isn't bad teeth, and I also feel it in what lymph nodes I have left in my crotch. So anybody have any experience with lymph problems?
Yeah, lymphedema.
Well, it's not so much like lymphedema, like swelling or anything. It's just there's another lympho something that's different than lymphoma, but it's disturbing to say the least, because it's been going on for 6 weeks, and I've lived nearly 60 years and never experienced this.
Are you getting any pain?
Sometimes, like tenderness and stuff, but and then pain. I thought my shrunken testicles were hurting again. I thought, oh, miracle. But no, it turned out to be like the remaining lymph nodes that are still there, like not in my legs, in my crotch. So I was like, oh, that's my lymph nodes. Huh. Just like my neck and the sides of my head. But we'll see. I've got a appointment with the dentist and then go back to see the internist next week.
Yeah, well, I'm really trying to cast my mind back, but we have had men who have had issues with their lymph systems as a result of being on ADT.
Like what else doesn't it cause? Right?
Yeah, exactly. So where they have had some swelling of their lymph systems, and I'd have to, I don't know if I can find it whilst I'm moderating, but I seem to recall trying to think who it was, but we've definitely had it. And so I think what I would be doing is you might want to push your oncologist, or you might want to talk to an endocrinologist and ask them about what is the what side effects can androgen deprivation therapy cause on the lymph system.
Yeah.
I mean,
I've had so many procedures done. It's like, hey, come on with the fine needle aspiration. You know, let's get it done. But they don't seem interested yet.
Well, you know, I mean, for example, we know that in the with the lymph system, excuse me, we know that with ADT it can cause water retention.
Yeah.
And water retention, you know, is something that I don't know enough about the biology, but I know it is tied into the lymph system.
Yeah.
So
yeah, this is just weird. I'll let you know how it pans out, but my money's on lymphoma.
Get out of here.
No.
Can I say something?
You may, Mr. Fish. Nice to hear you. We called on you before, but you disappeared.
I know. I dozed off. I dozed off. I see that I
Okay.
was asleep sitting here and I woke up. And I've
Well,
been.
we're glad you came back to life. What would you like to say?
So this is very coincidental because it's like my neck was hurting me or annoying me at night about 2 weeks ago for 2 or 3 nights, and I thought it was some kind of a muscular, and then I felt a lump in my neck, not right by the gland, but along the side, and I freaked out of my mind. And the next day, I went to see my regular doctor, who said, "Oh, it's just a swollen lymph gland. It's a lymph." And she said, "It's not cancerous because when you push it, it hurts and it moves. So that wouldn't be cancer. If it was cancer, you wouldn't feel it wouldn't be hurting by itself. It would be the pain would come as a result of growth that affected something else. It's more like you got an infection." And I started with a free NYU dental clinic van just because of that, because I was curious. Am I getting this stuff in my lymph nodes? And she said, "Well, we'll just call it lymphedema pathology, without undefined, and doubt that it's cancer, and doubt that it's related to anything. Maybe you didn't wear a scarf in your." She told me, "Put Salon Pass. Go get this, like a patch that has a menthol or whatever cayenne is,
Pepper.
yeah, like this little patch that you put on. They have two kinds. The hot one is the Capasium, and the other one is like menthol, camphor menthol patch. See if it goes down." I put that patch on, but I did have that one. I did get those those chills, the frozen, panicky feeling when all of a sudden I felt that lump right on my neck, the way you're describing. Well, you're describing it kind of generalized, but I have it very specific, and I'm still sitting here feeling it, trusting my doctor who said that that's not cancerous, but didn't see my oncologist yet, and thinking, should I really make an appointment and go to see her anyway? Anyway, it was very coincidental, and my doctor assured me it's not going to be lymphoma.
Well, let me just say, this is very coincidental because, God forbid, we need two moderators. We've got Joe and we've got Larry Fish who can start the new call. Okay? All right, guys. I hope that neither of you have anything more serious than something related to the cold weather and flying all the way to Prague in an airplane that probably had loads of bugs in it. Did you enjoy Prague, Joe?
I only saw the airport. I headed straight out to Pilsen, then down to Salzburg, and then back up to Brno, and then Prague again for the airport. Sorry.
Oh, okay. And what was the purpose of this trip?
Well, it's a business expense, so it was a work meeting, but I really just went to see some old friends. And oddly enough, a guy I hadn't seen for 20 years sat down next to me and he said, "Oh, I've heard some of your bad stories, and I'm a little bit in a similar situation." And it turned out the poor guy had a PSA. He's from Switzerland, and he had a PSA that's doubled twice, like 4, 8, 13 or something in a year and a half, and has Gleason 7 confirmed by 2 biopsies. And the guy's telling him, "Oh, don't worry about it." And I was sitting there going, I'd worry about it.
We need to get him on one of our calls, Joe.
Yeah, I've sent him off to make sure it's localized and find a Da Vinci surgeon that's done more than 1,000.
Good man. Okay. Okay. All right, guys. It's 8:03. We're going to finish on time. The next meeting will be the 26th. Yes, a week tomorrow. Don't forget, as we mentioned, that we have Speaking Freely, the call to speak about everything that is not medical, moderated very capably by Rich Jackson, with a couple of us in the background if as required, hopefully not required, and that'll be on Thursday at 8 o'clock. And come on and listen and try it. It should be a very good experience. It certainly was. The first one certainly was. We hope the second one will be. And that's about it. That's, I think, all she wrote for tonight.
Hey, Rick, Jake,
yes.
do you know when people listen to the recordings on YouTube, like a week later or 2 weeks later? I was listening to one from last week that Jake started with a little presentation on, and I was thinking, do you guys know? Do you get counts of how many people listen in?
Yes.
Okay.
We don't know who by name, but we do get a count.
Yeah, because sometimes I miss a meeting, and I really do appreciate those. Thanks.
A pleasure. A pleasure, a pleasure, a pleasure. And also thank you, all of you who wrote testimonials. We are now a 2019 top-rated nonprofit, great nonprofit. Thank you. Okay. Good night, everybody.
Good night.
Good night.
Thank you, Rich. Rick, thank you, Len.
Good night, everybody.
Good night.
Good night.
Right.